Everyone, we are about to begin.
Every movement begins with people united by a common purpose. People who stir up good trouble in pursuit of a shared vision for a better tomorrow and forge ahead despite adversity. Adversity is nothing new to us. Whether it's responding to the latest outbreak, addressing a crisis like syphilis, or striving to meet the needs of our communities, we will continue to do what it takes to get the job done. We are all here today with a common purpose: to fight for our communities, to stop rising STI rates, to forge ahead. We come representing every state, our cities, the territories, and the tribal lands. Together, as a movement, we are shaping the nation's health. Welcome to STI Engage 2024.
Please welcome Clover Barnes.
Good morning. We just heard from U.S. Congressman John Lewis in our opening video. He is one of my heroes. I've been known to create some good trouble myself, and that is a motto I live by and bring to the work I do every day as I shape the health and well-being of people who live and work in our nation's capital, our greatest city, Washington, D.C. No offense to all you New Yorkers and Miamians out there. We know you think your city's great too. In times like this, we all need to be creating good trouble. As we all know, STI numbers are on the rise, unacceptably high in America. Here in DC, we are just getting a handle on our congenital syphilis outbreak and working hard to use a syndemics approach to address HIV and STIs. We won't end HIV in America until we deal with the rising STI numbers. In this year alone, we have had to reduce funding for activities, and our DIS staff have been threatened by a federal clawback of money by Congress, otherwise referred to as the DIS recession. There is no doubt that we are resilient. We are tenacious. We are passionate about our work. And despite it all, we will persist until we succeed, despite the many, many challenges we face. We know how to create good trouble, and I am here today to tell you to create some good trouble here at STI Engage 2024, shaping the nation's health. Every successful social movement in America is defined by people of all races, ages, ethnicities, sexual orientation, abilities, and genders, coming together for a united purpose. People are the heart of our work, creating a movement to support sexual health rights of all Americans. Not only do I have the honor of opening STI Engage 2024, but I am also the new board chair of the National Association of State and Territorial AIDS Directors, otherwise known as NASDAD. NASDAD and NCSD are historic partners that work together every day at the national level. Our boards are more committed than ever to work together to confront syndemics. On behalf of Mayor Muriel Bowser, the District of Columbia Department of Health, and the division I lead called HOSTA, the HIV, AIDS, Hepatitis, STD, and Tuberculosis Administration, welcome to Washington, D.C. I hope you get a chance to get out and enjoy our beautiful city with its monuments, distinct neighborhoods and cultures, and the wonderful diversity that represents our nation's capital. Thank you.
Please welcome, from your Engage Innovator sponsor, Bavarian Nordic, Peter Costa.
Hi, good morning, everybody. I want to start by saying thank you to the conference organizers for having me today. And a big thanks to all of you for all of the good work that you do every day. So during my time with you this morning, I would like to reorient us on Mpox. And I want to ask you to remember 3 numbers. Those numbers are 25, 35, and 75. And no, I promise this is not the combination to an old high school gym locker. So 2 years ago, a rare disease called monkeypox, now known as Mpox, spread across the world, affecting over 100 countries, the majority of which are places where Mpox was not routinely found. And this is important because Mpox is a disease to which most people under the age of 50 have little to no immunity against. So it's no wonder that in May of 2022, when an outbreak of Mpox suddenly appeared in the US, that most of the population at risk found themselves susceptible to infection. And since then, more than 30,000 cases of Mpox have been reported. But this is where you all mobilized. This is where you all stepped up and got involved into communities by delivering timely education, raising awareness about protective behavioral strategies, and making vaccination available to those seeking it. In fact, thanks to your efforts, nearly 1.3 million doses of Mpox vaccine have been administered in the US. Yes. And that has helped to vaccinate 25%, fully vaccinate 25% of the affected population. So there you go. There's our first number, 25. The result of your work has been a dramatic and promising decline in Mpox cases. And this is attributable to a number of things, a combination of behavior change, immunity due to infection with Mpox virus, as well as immunity due to vaccination. However, CDC reports that Mpox transmission is unlikely to be eliminated. And in fact, transmission will continue, even if at a low level of transmission, but that in fact, it could actually reaccelerate if the virus begins spreading more readily. And so now this brings us to our second number, and that's 35. So according to recent modeling, most US jurisdictions have a 35% or greater risk of an Mpox resurgence, particularly if vaccination levels do not increase, and especially as new Mpox infections can enter from other areas, and as new never vaccinated or never Mpox infected persons become sexually active over time. So it's clear, right? We're not out of the woods just yet. And so this brings us to our third and final number, 75. Right now, 75% of the population most at risk for Mpox and eligible for vaccination is not fully vaccinated. So to help prevent another outbreak, US ACIP recently voted to recommend routine Mpox vaccination for persons aged 18 years of age and older that are at risk for Mpox infection. In response to this recommendation and to help make vaccination against Mpox more accessible, Bavarian Nordic is making its Mpox vaccine commercially available. And really this means 2 things. 1, Mpox vaccine will now be accessible to healthcare providers through their normal procurement and reimbursement pathways. And 2, and more importantly, Mpox vaccine can now be made available to those seeking vaccination at the types of locations where people typically go. Broadening access to Mpox vaccine has really been our aim since the very start of the outbreak, and it's our great privilege to be a partner to all of you to help stem the emergence of another outbreak. So I'll close by saying thank you again for all the work that you've done and will do in the days ahead. Remember, we talked about 3 numbers, 25, 35, and 75. 25% of the population most impacted by Mpox is fully vaccinated. The risk of another outbreak in the US is greater than 35%. And for the 75% of persons who remain unvaccinated, outreach must continue about protective behavioral strategies for preventing Mpox, including vaccination, which will become more and more accessible in the days ahead. So thank you again. Please connect with us at the Bavarian Nordic booths during the breaks, over the lunches. We'd really love to hear from you and listen to you and learn from you. And we hope to see you tomorrow at our Mpox presentation, which is 2 p.m. in the Georgetown room. So thank you again, and have a great session. Thank you.
Please welcome to the stage NCSD Board Chair from New York City's Department of Health and Mental Hygiene, Audrey McDuff King.
Oh, thank you. Should we sing? No, I'm just kidding. I mean, we can if you want to. So STI prevention is at a crossroads. And when I say the past year has been difficult, maybe I sound a bit like a broken record. We said this about COVID, about Mpox, about the DIS rescission, and it's true, but the STI prevention field has a long history and we are playing the long game. NCSD's vision is a nation where people live sexually healthy lives, and you are a part of the social movement to make that vision a reality. You are here to make good trouble, and every day you shape your community's health. It has been my honor to serve as chair of the board of NCSD. Your board of directors is one dedicated, passionate, and really fun group of leaders. We work every day with dedicated staff of NCSD, we chair board committees, we meet to develop strategy, define our policy and program priorities, and we take on a lot of tough issues. We also plan this conference. Sometimes we take unpopular positions on matters impacting our field that don't make everyone happy, but this is the definition of making good trouble. So members of the NCSD Board of Directors, please stand to be recognized. I cannot see anything right now, so. So a huge round of applause for these hardworking individuals who represent your interests at the national level every single day. So one of NCSD's core missions is to be a leadership training organization. By involving yourselves in board committees, representing your communities, lending your expertise, and raising your voice, you are learning new leadership skills every single day. The STI field is benefiting from this leadership more than ever, and I am so grateful for all of your hard work. I'm proud to welcome to the stage two very familiar faces, David Harvey and Harold Phillips. So last year, Harold joined us at STI Engage in New Orleans for a fireside chat with then DSTDP Director Leandra Mena in his role as Director of the Office of National AIDS Policy. Now he's at NMAC, and who better than Harold to help us hear from some past good troublemakers? I'm proud to kick off our opening plenary by bringing out Harold along with our own fearless leader, David Harvey. So please welcome David and Harold.
Good morning, Harold.
Well, good morning, David.
It is really an honor to have you back on the STI Engage stage. Yeah. When we last saw you, you were the AIDS czar in the White House. And now you have returned to us in the community by working for NMAC. We are so happy to have you this morning.
Well, thank you, David. I'm really honored to be back with you all.
Harold, are you ready to have some fun?
Why, yes, David. I'm always up for fun. What do you have in mind?
Well, I'm thinking we should be thinking a little bit about some TV shows. The View, Survivor, maybe The Dating Game.
The Dating Game?
I know, you're too young to remember The Dating Game, aren't you?
Not exactly.
But there are other people in this room who remember The Dating Game.
Are you saying, like, who would like a date with Leandro Mena?
Yeah.
Well,
How about a day with Gail Bowen?
I would love a date with Judy Wasserheit, actually.
I think for me, I am a John Douglas kind of guy.
Okay, like I'm tall. Great.
So, Harold, we have a date right now with some very special, brilliant people. Who the heck are these people?
Well, I think we have a date with some awfully brilliant people who used to work at CDC. In fact, I think we have not one, not two, not three, but all four former directors of the STD division at CDC, all at once for the first time ever here on this stage.
Knowing people want to know. They've been having all these conversations among each other. I want to know what they're talking about. But these four people, as you just said, Harold, really had never been in the room much together. And so, as you've already heard, this morning, we have the esteemed doctors, Judy Wasserheit, John Douglas, Gail Bowen, and Leandro Mena, who are the former directors of the STD division at CDC. They are going to tell us, they're all going to tell us some stories, we hope. And we really want to know what they talked about over drinks last night at the reception.
Yes, I saw, and stories I know they have to tell, David.
That's right, Harold. So all of you out in the audience today should know a couple of things. One, no one has slides. Have you ever been with CDC officials who don't have slides? I would like to compliment all of you on not having slides this morning. Two, we have rehearsed.
Oh.
We have done dress rehearsals.
Yes.
In fact, we may have rehearsed a little too much.
Yes.
In true fashion, during yesterday's dress rehearsal, one of my favorite people in the world, Gail Bowen, completely took charge. She reordered how we sat, and she proclaimed to everyone that I need a lot of help with facilitating this session.
Yes.
She announced that she wrote out in long form the answers to the questions that she's going to read from this morning. Gail, I may banish you from using your piece of paper. So, Harold, yes, I do need a lot of help this morning.
Well, I'm here. So our goal is to have a serious discussion about lessons learned and where our field is headed. But we also don't want to give this way too stuffy and too serious, do we, David?
No. We don't.
Okay.
That's right. So we want to warn our panelists. We might have some unscripted questions. They're looking at me with the evil eye now, see? Mm-hmm. We might throw you some curveballs, but nothing too serious. We want the real you. We want the real scoop. And we want to hear what you might never say if you were still working at CDC. So, Harold, I think we ought to get started.
Let's get started.
Yeah.
All right.
This is where we walk over. Good morning, esteemed colleagues.
Good morning.
Good morning, David.
Morning.
How was that for a little surprise? You ready, Gail?
Nothing surprises me with you, David.
Oh, we're off and running, Harold.
All right, we're off and running. So welcome. It's an honor to be here and have you all on stage. And as we start, let's set the stage for our audience. Why don't we start out by hearing from each of you, just for a few minutes and a few sentences, tell us who you are, a little bit about your era leading the division, and let's start at the beginning with Dr. Wasserheit.
Well, Harold, thank you. First of all, thanks to you and to David for pulling this panel together and for including me in it. It is such a delight to see so many friends and colleagues here and there and in person, not in our little Zoom boxes, right? I'm very honored to be here, but I have to say it's a little bit unnerving to be asked to reflect on things that we all did more than a quarter of a century ago. Like, how did that happen? But in terms of an introduction, I came to CDC in 1992. Bill Clinton was president, and David Satcher and Jeff Copeland led CDC during the time that I was division director. It was about 8 years after I finished my infectious disease training with one of the most remarkable people I've ever met, whose name will, I think, resonate with some of the people in this room, King Holmes. And my serendipitous path after that led me to work on STIs in 3 very different settings. First, in what was at the time the poorest country in the world, in Bangladesh, with rural women. Next, back here in the United States at the local level as Assistant Director of STD Clinical Services with Baltimore City Health Department, and also on the faculty at Hopkins. And then at the federal level, as the founding chief of what was then the brand new STD research branch at the National Institutes of Health. So having seen the impact of STIs on marginalized communities both domestically and internationally, and then also this huge gap between the really exciting research that was being done in STIs and what we were actually implementing in programs in the field, I came to CDC with a whole bunch of questions and some very strong biases about the things that we needed to try to change. So we had a truly stellar team in the division, and there are at least 5 things that I am particularly proud that we were able to accomplish during that time, although we clearly didn't fully succeed on some of those things. Number 1, we reframed and rebranded STIs less as infections and diseases and more about what people cared about and were more comfortable talking about. So the complications of STIs, things like preventing infertility and adverse outcomes of pregnancy, cancer, reducing HIV risk, and saving money. And that rebranding was really crucial in terms of helping us establish the critical partnerships that were fundamental to everything else that we did at the time. The second thing is that we started the Chlamydia and Infertility Prevention Program in 1994, and that was a great example of partnering with the Office of Population Affairs and with the family planning community. And we leveraged, at that time, innovations in the advent of non-culture amplification tests that had come through in about 1984, as well as 9 demonstration projects between 85 and 88. The third thing was the launch of the syphilis elimination effort, which started officially in 1999, but actually we'd been working very hard on it from about 1996, 1997 on. And that was an example of partnership with a whole range of community leaders, especially faith leaders in African American communities. Now, clearly we didn't succeed. We let the disease get away from us, but we actually brought primary and secondary syphilis rates to the lowest levels ever recorded in this nation. We broke the 7 to 10 year cycles of epidemics that we had been seeing till that point. The current epidemic is 24, almost 25 years out from the peak of the 1990 epidemic. And we also showed that we could eliminate syphilis in subpopulations even without a vaccine, although would have been great to have a vaccine. Would have been really nice. Number 4, we got the ball rolling on strengthening STI HIV program linkages. We leveraged data on the biological synergies and the results of the first randomized controlled trial looking at treatment of STIs for HIV prevention, which was in Mwanza, Tanzania, and came out in 1995 and showed a 40% reduction in HIV with STI treatment. But the combination of the advent of highly active antiretroviral therapy around 1996, together with the negative results of the next treatment trial, which came through in 1999, really stalled some of that progress. And then finally, we worked very hard on strengthening workforce capacity. We expanded training for public health advisors, including opportunities to get a master's of public health. We created opportunities for infectious disease fellows to add a year to their training and spend it at CDC to try to bridge that gap between academics doing research and public health people trying to implement programs in the field. And we supported the launch of NCSD in 1997 when it was proposed and organized by STD directors, some of whom actually are sitting right up here. So with that.
Great. Thank you very much.
And NCSD has been a pain in the ass ever since, haven't we? If truth be told.
Absolutely. So, John, same question. A little bit about your era and leading the division, and take us past Dr. Wasserheitz.
Take us past Judy, but back to the past. Well, I've been a little distracted thinking about my date with David ever since he said that. So that's still trying to get my head around that. So wonderful to be here again. Thanks to everybody who pulled this together. I'm a big believer in studying the past to help prepare for the future, and I really want to congratulate Harold and David for helping us pull together this past study to move forward. Like Judy, I came to the job at CDC from training in infectious diseases, actually also in Seattle and actually also with King Holmes. But I spent 19 years before getting to CDC in the trenches of local public health. I worked at the Denver Department of Public Health. I ran the STD control program there, did a lot of work with CDC, admired what they did, the potential they had to do more. And so when there was an opportunity to move to Atlanta and run the program, I was very excited. You know, I would say that the priorities when I got there, and I've served from 2003 to 2010, were to number one, continue and grow and build on the progress of the ideas that Judy had outlined. When I got there, it was already apparent that syphilis was maybe going to be a little harder to eliminate than we had hoped, but we weren't ready to have a funeral yet, so we kept working on that. We really pushed hard on chlamydia screening, and I love Judy's branding of why do people care about these diseases anyway, the infertility prevention program. And we're able to take advantage of just really, for us, one of the breakthroughs that were happening, which was social media. Now, social media, of course, has come to have a yin and a yang, a good and a bad, but it was a fantastic way of reaching folks that we'd never had before. Thirdly, we were mindful of gonorrhea control. We still had adequate antibiotics, but we're beginning to worry more and more about the slimming down of antibiotics as pharmaceutical companies begin to put more energy into lifetime antiretroviral medications, a lot less interest in single-dose antimicrobials for a disease like gonorrhea. And then we worked really hard on the new partnerships that Judy mentioned, particularly with the HIV division, but with also with other divisions within CHSTP, particularly the Division of Adolescent and School Health, because reaching adolescents, particularly strengthening sex education programs, is so important. We tried to build on the HIV partnerships through something, I don't know if the term is still used, it was kind of a cute term, PIXI, Program Collaboration and Service Integration, where we tried to bring together the different strands of our work. I think that was an important step. I was personally excited about the possibility of finally not a syphilis vaccine, but having an STI vaccine, an HPV vaccine, and the division had the opportunity to be the scientific lead in that area, which I think was important. I didn't mention the political context in which we worked, but it was important. I worked under President Bush, who at the time seemed like a challenging administration. We were having battles over whether condoms worked. We were having battles over what kind of sex education was appropriate, abstinence only, abstinence until marriage. Major distractions from the work of trying to really push on STDs. Of course, in retrospect, President Bush looks pretty good, but those were undoubtedly challenging. And you know, I'd say the final thing that we began to work on, I love the work that Judy's tenure did with our faith-based leaders. I was a big believer in that. We tried, as we moved along, to address frameworks in a slightly different way, which was sexual health. And it is incredibly pleasing to me when I hear this term is now that, you know, it's part of our nomenclature. We don't have to like stumble over the words. What does that mean? We really worked hard to sort of reframe the work we were doing because the morbidity mattered, but the health vision was, we thought, actually even more critical.
Great, thank you. Gail, you want to take us?
Again, thank you all for being here. Thank you, David and Harold. It was great for us to get together, even over drinks last night, and then later to discuss what we were doing today. So I'm going to start off by saying, for those who don't know me, I was director from the division from 2011 to 2020. Prior to coming to CDC, I entered the field as director in San Francisco in 1986, and after 11 years, moved to the California State Program for 12 years. I think we all know that few fields in public health are more dynamic and diverse than the STD field, and this was especially true in 2011. STDs were skyrocketing, state and local public health infrastructure was eroding, and federal prevention resources were woefully inadequate for the task at hand. Those are just a few of the problems I faced when I arrived. But probably the most important strategy implemented during my 10 years was to restructure our flagship STD prevention funding announcement, the biggest investment of the division, to be more realistic, flexible, and targeted to better address the challenges and the opportunities of the day, because Charlie Ravens would always remind me that if you've seen one STD program, you've seen one STD program. Thus, improving the STD programs through assessment, assurance, policy development, and prevention strategies known as APS was born. We're going back to the basics of core public health functions. I quickly learned, I'm not a very patient person, that change is hard and slow. This restructuring challenged enshrined ways of working and siloed thinking. I remember my first meeting with Dr. Frieden like it was yesterday. I thought he was going to send me back to California. He grilled me about this NOFO and this new approach because the White House had heard I was getting rid of IPP. I explained to him it was a health equity issue. The goal was not to sunset IPP, but to expand this exceptional partnership model that Judy had started and let states decide where to support chlamydia screening for young females most in need. A funding formula was also used in APS, a first for the STD field. We learned that the distribution of funds were not well aligned, if based on morbidity and population size, an equity issue again. Fortunately, Dr. Frieden approved this national approach despite dissent from many of his senior staff in the room at the time. The next version in 2018 was called Strengthening STD Prevention and Control for Health Departments, known as PEACH. It was the same framework, but a little more directed to expectations, as the needle for change in some areas had moved very slowly through the APS project period. So through these cooperative agreements, change was viewed as opportunity to improve impact of our STD prevention investments. Because I don't have time to go into all the details, I encourage you all Go back and read APPS if you can find it on the CDC website. And I think you have a copy of PEACH. And I'd just like to highlight some of the high-level changes that were included. So first of all, we felt it was important to strengthen program evaluation, policy development, and surveillance capacity in STD programs, and especially knowing that surveillance is the only public health function that is done solely by public health departments. And also, all of these factors really drive public health change. We de-emphasized DIS contact tracing for chlamydia and gonorrhea. We wanted to expand the reach of EPT and BYOP, known as Bring in Your Own Partner. We did basically say we were sort of eliminating the goal to eliminate syphilis. And we really wanted to increase investments in partnerships to expand the influence of STD prevention nationally, using the IPP model, especially with HIV, and after the Affordable Care Act, we tried with managed care. Now, as for the barriers at the time, as always, resources, but we've always faced barriers in financing STD clinical practice services. Now, I'm also proud of other work that the Great Division did to strengthen programs in the workforce, and I'm just going to mention a few in the interest of time again. We prioritized our investments in congenital syphilis. We mitigated the threat of untreatable gonorrhea. We defined and supported the implementation of quality STD services in STI specialty clinics and primary care settings with the help of the PTCs and EHE funding. We developed innovative screening delivery models through express visits, telehealth capacity, and self-testing outside of clinical settings. And we launched the DIS certification program. But lastly, I have to say I am grateful for having NCSD as a critical partner while I was at CDC, because I know I was a critical partner when I was in the field. And while at times, David, we just had to agree to disagree, getting feedback from those who do work at the local level to inform CDC thinking is invaluable and essential. My gratitude to all who helped me along this wild ride, and especially those who worked tirelessly under difficult circumstances at the local level, like many of you here today. It's been a privilege. Thank you.
Leandro.
Well, good morning, everybody, and thank you, David and Harold, for having us here. I mean, it's a true privilege. I mean, certainly to be here with my former co-directors of the Division of STD Prevention, that I'm always will feel privileged and honored to be part of this group. As many of my predecessors, I'm an infectious disease trained physician. I trained in New Orleans, Louisiana, under the benefiting from a tremendous mentorship of Dave Martin, Stephanie Taylor, Patty Kissinger. I moved to Mississippi because Mississippi was a place where I was offered a job that I dreamed to have at the end of my career. And it happened to be director of an STD clinic, working with the health department, being able to do clinical research. And I went there, convinced that I was gonna live in 3 years. And the person who hired me told me, the very first day, I'm gonna make it impossible for you to leave. And he did it in terms of giving me the freedom to focus on the things that I felt were important. I spent 20 years in Mississippi working in STI, HIV prevention, and really experimenting. In Mississippi is a place where you really can't ignore, right, the disparities. You really can't ignore the challenges, structural racism, and the impact that it has in people, and really recognizing that the health systems that we have in many places in our country are not really capable of responding to the needs of the populations that we're serving. So really, by the time I left Mississippi to come to CDC, I was medical director of 5 different clinics, and they all were in many ways different flavors of the same thing. Some of them were embedded into a community-based organization, community clinic. Some of them were just a testing-only clinic. Some of them were, one of them was a classic STD clinic. The other one was a very low-barrier clinic for people living with HIV. One of them was a multidisciplinary transgender clinic at the university. So again, many different flavors of the same thing. I was lucky enough to come to CDC in 2021, and that's where my story starts. I came in the middle of the COVID pandemic, and it was really interesting. I remember in August moving from Mississippi to Atlanta and looking forward to come to CDC, where the federal workforce was expected to return in September, but Omicron was coming, so all that got pushed back. And then I find myself, by myself in the office most days. I think, some of my colleagues like Laura Bagman, who used to come, to meet with me in person. But it was difficult in many ways. As coming from outside the federal government, right? There is a whole culture that I felt I wanted to make sure that I understood. And really understanding that culture in a place where no one is there, presented a challenge, not only to me, but as we were trying to onboard new people into the division, new leaders into the division. The COVID pandemic, I also found a workforce, both at the federal level, but also the state level, that was, eroded. By now 1.5 years, almost 2 years of the COVID pandemic, the STD services across the country, which have been eroded, right, over almost 20 years of underfunding or level funding, decrease in the state funding. I was preparing for this last night, that in the 1990s, 58% of the STD funding in the nation was pretty much state funded. By 2007, it was only 25%. And in my times, now, a large proportion of STD programs are actually no state funding. So the consequence of this has been a decrease in clinic operations, clinic hours, number of people being tested. That has been happening for more than a decade now. Mississippi in 2003 had almost 200 disease intervention specialists when I came in. By the time I left, there were less than 20. So again, it has been a tremendous erosion of our public health, capacity that has in many ways contributed, if not led to this, STI epidemics that we're living right now. In the other side, I think COVID gave us, a silver lining. I mean, certainly the $1.3 billion investment, presented a tremendous opportunity to start rebuilding that eroded public health workforce. It will give us opportunities to, identify important gaps that existed in STI in terms of diagnostics. At times, for some diseases like syphilis, we're using diagnostic technology that is, 6-7 decades old, without no evolution, that continue to limit, the ability to really diagnose, accurately people who may have active infection who need treatment. And we had the opportunity to, at the time that NIH was making changes into how they do infectious disease research and STD research by eliminating the STI clinical trial group, we felt important for CDC to step in to make sure that the population-based implementation research that was needed, especially to be able to adopt, translate those scientific advances that were happening, was there to be able to demonstrate and to effectively improve the population health. And then another, I think, important to mention, right, was the Mpox, outbreak and that happened, and how, again, the resilience, right, of our public health workforce that, in spite of how challenged we were and how tired we were, basically stood up and I think responded in a very, positive, effective way to the Mpox outbreak of 2022. Then we have to deal with the challenge of losing, that big investment.
Heartbreaking.
In the most challenging times, and to adjust, right, to the economic realities, that we had. But again, it's something that I'm confident that we are gonna do and we're gonna continue to do. So it has been a great time.
Thank you. Harold, that was a wonderful tour over the last 25 years of some major developments in our field, and very succinct.
Absolutely.
Gail, you did a great job. All of you did a great job. I have a quick follow-up question. All of you, in one regard or another, talked a little bit about the influence of politics and policy on what you could and could not do in your positions. So So I think my very quick follow-up question for you is, in one sentence or less, what was the most surprising thing you learned after starting to work in a federal agency like CDC? Gail, want to go first?
Again, I came with my
One
bias.
sentence or less.
Oh, okay. What I learned was, boy, are there a lot of laws. and sometimes people were not questioning why we were doing things a certain way. And I did learn that the only thing that you can get fired for is if you misuse funds and break a law.
Uh-huh.
So if you know that, you can figure out how to work in federal government.
What? A lot.
Sorry, I went over.
Harold can identify with
That's a good
this,
one.
having been in the White House.
That's a very
Lots
good
of
one.
laws, policies, regulations to follow. Judy.
Well, I think one of the most surprising things to me was the contrast between the way NIH dealt with policy and policymakers and the way CDC dealt with policy and policymakers. So at NIH, the rules were the same. You really weren't supposed to officially interact with members of Congress, their staff, the White House, et cetera, et cetera. But at NIH, you were next door, and you interacted all the time. And that was a really important thing. And at CDC, the notion was, we're in Atlanta, we're going to keep our heads down, do what we want to do, and try to avoid interacting, or at least keep it really under wraps.
Right.
And I think that was a liability. I think that was a real problem.
I think, yeah.
The policymakers kept turning to NIH, and we needed them to turn to CDC.
Yeah, really.
Yeah, I'm glad you said this, Judy. For people in the audience, people who live, eat, and breathe this stuff in Washington, Harold, it was always amazing to me to hear policymakers talk about public health and our field, and they're really talking about CDC, but they're talking about NIH, because they don't understand the difference. And so I think that's a very important point. Our government relations consultant, Betty Lou Taylor, who many of you know, who I think is with us this morning, will tell you that the huge federal sucking sound that comes out of the appropriations committees in Congress is NIH. NIH gets used funding increases every year. At CDC, we fight for every scrap, don't we? John and Leandra, very quickly, how would you answer that one question? And then, Harold, we're going to mix it up a little bit.
Okay.
I'm going to turn to you. Yes, John.
First, I want to agree with the proximity issue. There's a reason Dr. Fauci is on Capitol Hill right now before a committee, rather than somebody from CDC. It's the proximity. Secondly, for me, the surprise was Battleship. How big it was, how much more complicated it was, and how hard it was to move it. But when it got moved, it could be very impactful.
Leandra.
I think I want to build on what Gail said. That constitutional environment was really, different. But I'm going to provide a little bit more nuance, because that constitutional environment creates some tools, that you have to learn how to use them, and then there is a timing on when to use them, right? That is really very unique, and it takes you, more than 1 year to figure it out.
Gotcha. So, Harold, we're gonna dig into syphilis in just a minute.
Dig into syphilis. I was just gonna say, David, I love the fact that all of them came from the field.
Yeah.
Into federal government and federal service.
Yeah.
Because I've often found that folks who have that experience really understand the impact of what we're doing sort of at the federal level around program and policy, and having had that lived experience of what this means on the ground, it makes a difference. And often when I've been in meetings, I can tell when someone has that contact and they understand that and know that sort of those decisions that we make in the conference rooms, whether it be Atlanta, DC, or Rockville for HRSA, that it has real impact, it has real meaning, and that experience that all of the directors talked about, all of them sort of coming up from the field and coming into the federal government and using that power and that influence is great. I also think that, the distance between Capitol Hill and Atlanta, I think during COVID, and I think you all are also responsible for this, during COVID, for the first time having conversations with my family about what a disease intervention specialist does, or contact tracing, and that's a real thing and how that happens. I think there was a missed opportunity to capitalize on that when we were all as a nation having those conversations and really understanding what this workforce does. And being able, I think if CDC had been closer, more in contact, we could have really propelled some things forward as people were really paying attention to public health in new and different ways. But speaking of public health, let's talk about syphilis. And I think, David, as you have said,
yes,
we want to talk about sort of the new syphilis epidemic and what's happening and some of our efforts.
And Harold, you picked up on a really interesting theme. Maybe you can comment on this later on. Should CDC move to Washington, D.C.?
Oh, dear. maybe think about, there is a Washington, D.C. office, but thinking about the configuration, who's there, and sort of their relationship with Atlanta and with the rest of D.C., I think would be helpful.
Yeah, it's an interesting question.
Yeah.
So we're going to dig into syphilis, but I want to lighten the mood for just a second. We told you we were going to surprise you all. Are you ready, Harold?
Oh, you want me to
go first,
do this?
Or you want me to?
You want mine to go first?
I want to know.
To lighten the mood a little bit before we jump into syphilis?
You go first, Harold.
Which is not a light topic. So we've heard a lot about your accomplishments and what you've done in your positions during your tenure, but I'm going to take it back a little bit. So when you were a kid, what did you want to be when you grew up?
You're looking at me.
Yeah.
Okay. My mom was one of the first women in podiatry. So, of course, I wanted to be a podiatrist because I thought she rocked. And she told me that I couldn't be a podiatrist. I needed to be a doctor because the scope of practice was larger. And then if I wanted to be a podiatrist, I could go back. So from the time I was about 4 years old, I wanted to be a doctor.
And I love that because your mother was pushing you to think big. So I think Mom should be very proud of what you've done and accomplished. John?
Oh gosh, what a question. I toyed with lots of ideas. At one point I thought I'd write the great American novel. That never happened. My ninth grade career paper was on being a commercial fisherman, because I like the beach, so that's probably my most formal.
That's great. Gail?
So I loved being outdoors. I like to explore, and I wanted to be an archaeologist.
Archaeologist.
Good one.
I didn't think about medicine until after I worked at NIH after college.
Okay.
When my mentor there said, don't get your PhD. You should go to medical school. So.
Indiana Bowling.
Leandro.
As far as I can remember, I always wanted to be a doctor. I was fascinated by science and how the body works. So.
That's wonderful.
All right.
That's wonderful. Now, we don't have that much more time in this panel. Boy, did this go fast. But very quickly, we want to know who your celebrity crushes are. Let's get to the really important stuff. John?
God, ever since you told me I was going to have to answer this, I've been racking my brain. So I'm really old, and I think the best I could come up with was Joni Mitchell, who was my
All right.
All right. Very good. Judy?
Well, I don't do celebrities. My celebrities are like in this room.
Oh, that's very nice. Very nice. Gail?
When David said he might ask this question, it was like, oh, really? But I did actually have one, and it was Jackson Browne.
Oh,
Jackson Browne. Oh, all right.
Okay. Just one, huh? All right.
Jackson Browne.
Leandro?
So in a very weird way, I really didn't have a celebrity crush, but I had to think, who were my crushes when I was growing up? And I realized that all my crushes were people that I had within reach, you know? So I'm more a realistic kind of person, I guess, when it comes to crushes.
Right.
All
That's
right.
good.
Very
That's
good.
good. All right, with our remaining time, we're gonna have to be very focused. We have
Yes.
2 remaining questions, one on syphilis and one really kind of focused on where is our field going? Based on all of your expertise and knowledge, what advice are you going to leave us with this morning? So as you ponder the answer to the second question, let me pose the first one. We've touched upon some of these issues already, but syphilis cases are at the highest levels they have been in our lifetimes. And we obviously have a huge new spotlight on syphilis nationally, through the work of this administration, and at this conference, we're going to be talking a lot about syphilis. How did we get here, and what changes to prevention strategies do we need to better combat syphilis? And your answers will have to be in 3 sentences or less. Gail. I'm just kidding.
Right.
3 sentences or less.
But John, why don't we go to you first?
Oh my, how did we get here? I guess I'm thinking of a couple of things. First of all, I think it's pretty apparent that the extraordinary successes of HIV treatment and prevention have turned a fatal disease into something that can be lived with. And yet, just as with COVID, when we kept kids out of schools, we had a mental health problem. When we have success in preventing HIV infection, we have the opportunity for people living their lives to experience other things, whether it's car crashes or syphilis. Second, it's public health infrastructure. You know, public health infrastructure, which was the topic du jour during COVID, has, clawback, et cetera, sort of gotten, as it always does.
We're already on our way back down.
Neglected again, yeah. And then I think we would have to acknowledge the substance abuse epidemic is more extraordinary than it's been any time in my public health career, and this is undoubtedly playing a role.
Thank you, John. Judy.
Well, I always think you need to start with the epidemiology. And so, this epidemic is in women. The greatest increases have been in women compared to increases in rates as opposed to absolute numbers. In women, the rates are highest in American Indian and Alaskan Native communities, and second highest in non-Hispanic, Black, and African American communities. But once again, this is highly concentrated. Half of all new cases of PNS syphilis in 2022 were in 2% of the more than 3,100 counties in this country. And that makes the disease really vulnerable. You can get your head, your strategies, and your resources around 1 to 2% of counties, right? So it seems to me there are 4 things we need to focus on. First of all, as we learned from the last go-round, community engagement and partnerships. Second, funding. You need the resources. Third, framing, which I talked about at the beginning, but the framing is critical to getting the community engagement and the funding. And just to clarify this, one of the biggest lessons I learned as division director was from a call from the Clinton White House late one Friday in December. And they said, Dr. Wasserheit, the president would really like to put some resources into syphilis elimination in his budget request. So we need a few sentences from you. And I said, sure, this is great. They said, there's just one thing. You can't use the word syphilis. So the lesson to me was that we were never going to be able to move syphilis elimination forward, either in terms of funding from Congress or in the communities, until or unless we reframed it as being about healthy babies and decreasing racial disparities and decreasing HIV transmission and saving money. So we gotta think about the framing of this. And then the 4th thing is we gotta make sure that the tools, the human resources, and the health systems are ready for this. So we need bicillin. We need tests. We need well-trained providers of clinical and partner services.
That's great. Leandro and then Gail.
I think if you look at the graph in the back, right, we can see that we're not where we are just suddenly, right? This is something that has been progressively happening and with a totally inadequate response to what's been going on. So I think that we have to somehow, advocate for adequate funding to be able to respond to the syphilis epidemic. And once we have the funds, that will never be enough, make sure that we distribute them in a way that is equitable to where we have the highest, incidence and rates of this epidemic. And within those geographic areas, as Judy mentioned, that makes total sense, the populations that are disproportionately affected.
Thank you. Leandro. Gail.
And so I think that both Judy, John, and Leandro have covered a lot of the things that we need to be thinking about. So I'm going to sort of build on that as opposed to repeating that our safety net structure in this country, social safety net, is completely eroded, as well as the public health infrastructure. So I'm going to come from the perspective of we do have some money, and I don't think we're going to get a lot of money soon. So let's do what we can do with the money we have. And what I would say is there are things that we can do better. Again, focus where the problem is, where in the counties where you've got a problem. Second of all, let's start with doing more for congenital syphilis. I've always said one case of congenital syphilis is unacceptable. And I think if we can look at things in a variety of ways, we can get to partner services through congenital syphilis. But we can also get to the gaps in the healthcare system that are occurring today. Women are not getting screened. If they're getting screened, they're getting referred to the health department for treatment and get lost in the system and never get treated. They don't get that third screen. There's so many things that we can do. I realize it's a little bit late. It's a little downstream. But I think if we could focus some of our existing resources and move them away from things that are just lower priority, I think that we can make an impact on congenital syphilis.
That's great. Harold, you get the last question. Many of you have touched upon this last question, which is, where are we going? What does the future look like? And Harold, you're going to ask the final question, but I want to add just a very quick component because we're already over time. In a private moment, what would you advise Dr. Laura Bachman, who is new in the role as your as director of the STD division? So that's going to be the part B to the question you're going to frame.
That's part B.
Harold.
Okay. So my question is, what advice do you have to the field? So I guess we'll do, what advice do you have to our audience moving forward? And then what advice for Dr. Bachman in the role? Want to start? Okay, Leandro.
I can start
on this.
Leandro.
I would say that all epidemics are local, right? So I think that while the federal government provides guidance and provides resources, it's really at the local level that we have the responsibility to really identify where the biggest needs are, and work with the community, to then, and this is something that I don't think we are really used to doing STDs. I mean, HIV has a much better track in terms of engaging community in designing, in implementing and then evaluating the impact of different strategies. So I think that's what my advice will be. At the local level, we really have to, these epidemics are local. We have there's a local context that is, I think, essential, right, for effective implementation of some of the guidance that is provided at the federal level.
Every person in this room wants to give you a standing ovation. I think we all identify with what you just said. Local control, local input.
Yep. Good.
Gail? So I think I would like to add, and it hasn't been discussed today, that the field is lucky to have two sort of refreshed national strategies. The federal STI strategic plan and the NASEM report on how we're going to move forward and look at things in a more holistic sexual health approaches. And I think there's a lot of really important information in those reports that I think are relevant today. And we should, I think, recognize the power of communities and the power of partnerships. And stop sitting at the apex of the health pyramid and try to move down to more environmental changes and change the context of people's lives so that the healthiest choice can be the easiest choice.
Great. Thank you, Gail. Yeah.
John?
I guess I would say to everybody, you guys plus Laura, think in terms of concentric circles. Those circles being, the bullseye is core public health work that you guys embody. The second is the work that is incompletely realized of our healthcare delivery system. We've mentioned issues of access to healthcare. The Affordable Care Act was going to fix everything. Yeah, not quite. And then the third concentric circle is the broader community. Our schools, our community-based organizations, our methods of communication, because they're all going to be part, I think, whether it's syphilis or monkeypox or other STIs, of really addressing the issue. For Laura, I would say, drill down as much as you can on the recent, before it completely goes away, lessons from COVID. We got to regain trust. That's true for public health in general. We've got to take advantage of what public health, when it's mobilized, look at the vaccination program, can really do. And we've also got to point to the successes that when you warp speed, really want to develop something, whether it's a panel of rapid diagnostics or vaccines, you can do it. And if you really want to deal with syphilis, think about that lesson and don't just take the same answers we've been getting over and over.
Right.
Great.
Thank you.
Judy.
Well, I loved hearing these responses. These were great. I knew this question was coming, so I actually wrote down, in the interest of time, my 2 sentences. And they would be the same, actually, for the field and for Laura. So during the last 80 years of our U.S. national STI prevention and control program, the real game changers have flowed along 2 synergistic tracks: innovations in technology and innovations in implementation strategy. And that sort of creates what John O'Merman and I have been working on a project a lot lately, and we've started talking about this as a virtual double helix that has to come together to move things forward quickly. So the pace of change actually on both of those tracks has never been faster. And I think that if we can focus on these dual sets of innovations and bring them together with better communication, better listening, and better partnerships. I think, we've all talked again and again about partnerships, public sector, private sector, across different other sectors. I think if we can bring it together, the future looks incredibly promising, whether you're talking about syphilis or infertility prevention and chlamydia or any of the other STIs and public health in general. So thank you.
That's great. Harold, you have been a wonderful co-host of this session. Thank you.
I'm glad I could help, David.
This has been a really fun dating game. We've gotten to know you in a whole new way. So thank you very much for today. And we are going to be sending you a little momentum from today's event. And I think there's going to be a picture shown, but you're going to get an NCSD crystal vase that's inscribed to you with your tenure during your time at DSTDP.
Whoa.
And there is a picture.
That's beautiful.
So thank you. Thank you all very, very much.
Very lovely.
We're over time. Our production team is going to kill us, Harold. But this has been a wonderful discussion. Thank you all very much.
Thank you.
David, thank you.
Good.
Thank you.
Thank
It was
you.
good. Very good.
Please welcome a few of your 2024 DIS scholarship winners.
All right, we just wanted to make sure you were awake. Good morning, everyone. I'm Erin Bean, but please feel free to call me Bean as we explore this conference together. Like more than half of you in the audience, we're disease intervention specialists. I personally have been a DIS at the Colorado Department of Public Check. Okay, it's working. Thank you. I personally have been a DIS at the Colorado Department of Public Health and Environment for the last year and a half now. As STI professionals, we work directly with members of the community in an effort to protect them and to respond to their needs and to facilitate their health. Our positions require us to be ready to respond to every outbreak and connect people with the latest innovations and interventions. And when we help our neighbors address complex, interconnected issues, we are often at the forefront of the movement. Over the next few days, we'll delve into the latest biomedical advancements in our field, such as DoxyPEP, a promising post-exposure prophylaxis that can reduce one's risk of acquiring chlamydia, syphilis, and gonorrhea. This promising biomedical intervention is currently set to reduce STI transmission amongst people assigned male at birth. As someone who primarily works with young women and pregnant individuals, I urge us all to keep in mind cisgender women, trans men, and all folks assigned female at birth. This is a group that deserves more comprehensive studies and the use and efficacy of DoxyPEP to avoid recreating similar inequalities we see with PrEP use for HIV prevention among this population. Biomedical interventions are only as successful as they are accessible. It's imperative that we take into account medication costs, access to healthcare, stigma surrounding and accessing these services. We must ensure that DoxyPEP is built into and around the needs of the folks whom we have historically underserved or missed as we build to these prevention campaigns, not limited to individuals who are unhoused, undocumented, BIPOC, imprisoned, or from diverse age, gender, sexual, religious, and/or social backgrounds. So as we continue throughout this conference and beyond, let's commit to advancing with inclusivity and equity in mind, ensuring that no community is left behind on our journey toward progress. Thank you.
Hello. My name is Marcy Athey Graham, and I currently work at a local health department in Nebraska. So a little bit about Nebraska. Yes, there are more than cornfields, and yes, people do have sex. Okay, I'm glad everyone laughed. So I have worked in public health for about 14 years, mostly at the state level, in HIV surveillance and managed the STI program for almost a year. And then now I'm at the local health department doing DIS work. The topic I was asked to speak about is syphilis, which everyone is talking about. So our preliminary data in Nebraska for 2023, we don't have that all compiled yet, but between 2017 and 2023, syphilis in Nebraska increased by 502%. Our congenital syphilis increased by 1,300%, meaning at a point in time we had no congenital syphilis cases, and now we do. We are trying to come up with all different kinds of ways to address syphilis in Nebraska, one being really trying to make connections with our maternal and child health folks, meeting with our corrections folks. DIS at our local health department are going out to prisons once a week and going out to our county jails once a week. A lot of times we are seeing folks in those settings that have had no medical care or no medical home, and they're just finding out that that they have syphilis, and they're not even sure, is it new, is it old, is it been treated, has it not been treated, were they treated appropriately? The other thing that we're doing, which is easy to do in Lancaster County, is field visits. We're trying to meet people where they're at, going to their homes, meeting them where they feel comfortable meeting if they don't want to come into the health department. That is not always easy for DIS that support the rural part of our state, because you can sometimes, our rural folks they're located in Lincoln, but they could travel up to 6 to 8 hours to meet with somebody in their home or meet them at the doctor's office. With the supplemental funding that we had, we were able to have DIS at those local health departments across the state, which was a benefit. And we're hoping to be able to sustain that in some other way, but at this time we're not sure, as probably most folks aren't. The last thing is, I guess the majority of our cases that we've seen with syphilis have mostly been in men, but recently, probably in the last couple of years, we are seeing higher rates in women. And it's affecting mostly Black folks and Native folks. We are seeing rates among Native folks 11% higher than whites. We're seeing 7% higher, excuse me, not 7%, 7 times higher than whites for Black folks. And so we really, just like Bean said, we really need to try to meet people where they're at and come up with creative ways to test, treat, and talk to people about partners so that we can get everyone tested and then treated. So with that, we'll talk about the penicillin shortage.
I'm Jolene Rios, and I work for the CDC Foundation as a contracted DIS for the Arizona Department of Health Services. When the CDC announced the benzathine penicillin G shortage in April 2023, our team of STI DIS worked with our leadership to develop a plan to monitor the supply of benzathine penicillin G available to our partners. Our agency used surveillance data to project county-level needs for benzathine penicillin G and developed a strategy to monitor the county, correctional, and Indian Health Service clinics' benzathine penicillin G supply. The projection codes estimated benzathine need based on number of cases, stages of cases, and actual doses prescribed. The STI DIS team took significant steps to address this challenge. We initiated monthly outreach calls to county health departments, correctional facilities, and Indian Health Service, as well as tribal health facilities. These calls focused on monitoring our partners' benzathine penicillin G supply, assessing conservation efforts, identifying barriers in obtaining field orders, and checking the expiration dates of existing supplies. We also provided partners with resources for guidance on dose conservation. We then compared supply information collected by DIS with the projected need from our surveillance data to prioritize support for jurisdictions that were running low. These efforts ensured our partners had the support they needed, particularly when unique situations presented themselves. This was especially crucial for low-volume public health clinics in care deserts. Some facilities faced significant challenges with expiring supplies before the shortage ended, leaving parts of rural Arizona without benzathine penicillin G for months. The data gathered by the DIS team was vital in alerting our leadership to potential shortages or expiring supplies. Throughout this process, the DIS team demonstrated exceptional collaboration, care, and support, fostering positive relationships with our partners. True to their nature, the DIS were ready to take on new challenges and navigate uncharted territory to overcome obstacles and create systems that work, ensuring our partners maintain a supply of syphilis medication to treat their patients. One DIS on the team said, "I think just having contact with providers and hearing their grievances made it all less isolating." On behalf of Arizona, thank you all for being here.
Hello, everyone. My name is Gina Caesars. I'm a community health specialist with the Southwest Suburban Health Department in West Dallas, Wisconsin. If anybody's from Wisconsin in the room, there you go. I've been asked to speak about the impact that the pandemic had on DIS. So I think we can all agree that the pandemic left the public health workforce and the healthcare in general in burnout mode. In addition to DIS for COVID, there was still a need for DIS for all communicable diseases that included STIs. So a statement from the CDC said that we may never know the full impact that the pandemic created on STIs, reporting that there was likely an increase in transmission and underreporting of the illness. Personally, I think it's because many people at default was Netflix and chill, so I'm not really surprised. But in all seriousness, people were just taking great risks to be around one another. So with COVID DIS, we spoke with 12 to 20 people per day for contact tracing, and that barely made a dent in our caseload. So we definitely learned a lot about high stress and communication. But in spite of all the burnout, I just want to focus on the positives. So here's a few valuable takeaways that I got from it. Some of us in our lifetime have never seen an illness that swept over an entire globe and killed many. And now we have. So we've learned so much about disease transmission and control. We learned that many people, we probably knew this, but many people were willing to take high-stake risks just to be with each other, and they desperately needed the education to keep them safe and conquer misinformation and disinformation that's out there. We learned new techniques for communicating with others during this very polarized time. So it was kind of like learning to speak a new language with every new person that you spoke to. Everyone received it differently, responded differently, and it wasn't always friendly. In my caseload over the past year, I've seen a number of chlamydia and gonorrhea cases increase, especially co-infections, and those have been significant. So still operating off the exhaustion of contact tracing, and now having so many STIs, most notably, where we have our young people under the age of 20 on their 10th or more STI. So it could be really easy to feel the gravity of it all. But when I take a moment to think about the opportunity to provide education and support to others, armed with these new and improved communication skills and all the new approaches that we learn, I feel hope that we can, we do, and we will make a difference. So though the impact of COVID on public health workforce has been overwhelming, I just want to highlight one silver lining for all of us, that we as DIS and public health are filled with fierce resiliency. So we'll give ourselves a hand for that. Yes. So just don't forget your self-care so that we can keep on keeping on. So in that, like you, we are playing an essential part in STI prevention right now in our communities. And having us, a strong STI workforce, a movement of professionals working in every community to prevent STIs will always be important to shaping the nation's health. Thank you.
Please welcome to the stage Acting Director of the CDC's Division of STD Prevention, Dr. Laura Bachman.
Good morning, everyone. I'm delighted to be here with all of you today in our nation's capital. Many of you in the audience are directly involved in STD programs and see firsthand the challenges that we face in the STI epidemic. Some of you are also engaged in developing promising innovations and that will strengthen our response to STIs. Earlier, you had the opportunity to hear from 4 previous CDC Division of STD Prevention directors who shared experiences and insights that they faced over the past 4 decades. They've also highlighted some solutions and innovations that emerged during their tenure. While some challenges and threats remain the same, we also have new opportunities, such as increased interest in coordination at the federal level, support for sexual health clinical infrastructure and a syndemic approach, as well as some promising prevention tools on the horizon. In recent years, the STI field witnessed the emergence of critical issues that have demanded our attention, resources, and innovative approaches. Within the STI epidemic, syphilis is one infection that stands alone. It has emerged as our unique challenge. As syphilis rates increase among women of reproductive age and their sexual partners, we're witnessing an alarming consequence: a surge in cases of congenital syphilis. This has received national attention, and last November, CDC released an MMWR vital signs on missed opportunities for preventing congenital syphilis in the United States. The report found that a lack of timely testing and adequate treatment contributed to almost 90% of congenital syphilis cases in the US, and that 40% of people who had a baby with syphilis did not receive prenatal care. This vital signs report underscores the critical importance of addressing missed opportunities for syphilis prevention. Implementing tailored strategies at local, state, and national levels could improve key areas and reduce congenital syphilis rates and complications. In response, DSTDP leaders and scientists are working with senior leadership at the U.S. Department of Health and Human Services and other federal partners on the National Syphilis and Congenital Syphilis Syndemic Federal Task Force. The overarching mission of this task force is to address the syndemic of syphilis and congenital syphilis, to reduce their rates, promote health equity, and share resources with impacted communities. The establishment of this task force signifies a commitment at the national level to prioritize syphilis prevention efforts. It recognizes that tackling this complex issue requires collaboration, coordination, and evidence-based approaches. Now, you'll hear much more about this task force tomorrow from Assistant Secretary for Health, Admiral Rachel Levine. But I do want to make the point that CDC staff are co-chairing several of the federal task force subcommittees. While we must apply the tools we have more effectively and in new settings, innovative strategies are needed to expand syphilis screening and improve linkage to treatment, such as increasing the use of existing point-of-care tests in non-traditional settings. Additionally, investment in research and development of new point-of-care tests with enhanced performance characteristics could further accelerate syphilis diagnosis and treatment, breaking the chain of transmission. Alternative drug therapies are needed, as is necessary, as seen really through the Bicillin LA shortages, faced multiple times over the past several years, including the shortage that we're experiencing now. The Mpox public health emergency is another issue that has demanded our attention, our resources, and a syndemic approach. Underlying drivers of disparity in STI, HIV, and Mpox prevalence and outcomes are intersectional in nature. The drivers include systemic homophobia, racism, and differential access to care. The impact of the Mpox outbreak has been significant on STI clinics, forcing them to redirect limited resources and staff to respond, all while learning how to manage an old pathogen that is being transmitted in a new way. CDC played an integral role in elevating the nation's response to the Mpox epidemic, which followed quickly on the heels of the COVID response. Through partnership with those of you on the front lines and in the community, cases have decreased dramatically, but they have not disappeared. Using a health equity-centered and community-based participatory approach, we promoted and distributed a safe and effective vaccine while rapidly mobilizing and engaging with affected communities. However, research conducted by CDC revealed that less than 1 in 4 individuals who could benefit from vaccination had been fully vaccinated. Increasing vaccination rates among affected populations remains a priority for us. As global and domestic Mpox cases continue to present a challenge, we will continue to deploy staff and resources and gather input from the community. Effective public health messaging is a key component of any national response and is consistently strengthened by community engagement. We are hopeful that the lessons learned and partnerships forged from the Mpox response will strengthen our messaging efforts and implementation of DOTC-PEP. Now, as many of you know, the use of DOTC-PEP is a significant development in STI prevention. For those of you who may not be familiar, DOTC-PEP is the use of doxycycline post-exposure prophylaxis for preventing syphilis, chlamydia, and gonorrhea. Traditionally used for other purposes, doxycycline has shown promise for preventing bacterial STIs among men who have sex with men and transgender women when administered within 72 hours of exposure. DOTC-PEP offers providers an additional tool in our arsenal against STIs, and it's a valuable addition to our comprehensive package of sexual health services. This approach highlights the importance of exploring new avenues for STI prevention beyond traditional methods. However, we face challenges to our ability to develop new approaches to STI control. Budget cuts have become an unfortunate reality for many public health programs, including those dedicated to STI prevention and control. CDC's STI program continues to maximize the impact of the available resources to prevent the largest number of infections and increase health equity. We are very appreciative of the investment that CDC received in the DIS workforce through the American Rescue Plan. This funding has done what it was intended to do, to hire and train DIS who are reflective of their communities. Unfortunately, the DIS workforce funding was included in the rescission and is impacting programs. During recent notable public health outbreaks, such as COVID-19 and Mpox, CDC recognized a need to be able to directly fund safety net clinics that provide sexual health services. To address this need, CDC issued funding awards that have provided direct support for the provision of STI and related services across the U.S., including support opportunities for syndemic-focused activities. It is critical that people have access to high-quality clinical services in high-morbidity areas, and CDC is seeing success from our syndemic investments in STI clinics. However, flat funding and more reductions pose significant challenges. They limit our capacity to develop and implement comprehensive STI prevention strategies, to provide accessible testing services, and deliver timely treatment options. As a result, populations at higher risk and who may be underserved are disproportionately affected. Investing in STI prevention is not just a matter of public health, but it's also a wise economic decision. The costs associated with untreated or undiagnosed STIs are substantial, from increased healthcare expenditures to lost productivity and adverse impacts on individuals' quality of life. By allocating sufficient funds for prevention efforts, we can save lives while also reducing long-term financial burdens. As we navigate the challenges posed by syphilis, Mpox, antibiotic resistance, and other emerging issues, it is clear that no single approach or entity can effectively address the complex landscape of STI prevention. CDC and publicly funded STI programs cannot address the STI epidemic alone. We must engage policymakers, community leaders, healthcare providers, and affected individuals in conversations about the importance of investing in public health initiatives. Collaboration across sectors, healthcare, research, policy, and community is essential. We must also prioritize innovation, whether in the form of new diagnostic tools, alternative treatment options, or creative strategies for reaching underserved populations. By working together, strategically allocating resources, and embracing novel approaches, I believe we can make significant strides in the fight against STIs and build a healthier future for all. Thank you.
Please welcome Mario Perez.
Buenos dias, and greetings from California. In 1962, the United Farm Workers was founded by Cesar Chavez and Dolores Huerta. They both worked tirelessly to empower migrant farm workers, increase their wages, and improve their working conditions. In the words of Dolores Huerta, every moment is an organizing opportunity. Every person, a potential activist. Every minute, a chance to change the world. Colleagues, we are gathered here in DC to disrupt the forces that threaten our nation's sexual health. Even more attention, even more action, and even more deliberate progress is needed. In Los Angeles County, like in many corners of our country, we are experiencing record levels of STDs. A congenital syphilis crisis fueled by substance use disorder and limited or no access to healthcare delivery systems, and, depending on the STI, disproportionality across race, sexual orientation, gender identity, and age groups, and regrettably, also a stagnant decline in new HIV infections. As we heed to the words of Dolores Huerta and continue to help organize this movement to improve sexual health in America, and as we activate across local, state, and federal levels, and as we instigate change through progressive budget and program policies, we must also unite around a plan and support the stewards of that plan. In a moment, we will hear from Nate Fessick, the Senior Advisor on Syndemics at the U.S. Department of Health and Human Services. He is responsible for guiding the operationalization of the federal STI implementation plan that is part of the National STI Strategic Plan. The federal implementation plan is galvanizing resources to combat rising STI rates from 5 federal departments and no less than a dozen centers, administrations, and offices at HHS. As part of this movement, our colleagues at CMS, SAMHSA, HRSA, NIH, the VA, the Office of Women's Health, the Office of Minority Health, and HUD, among many others, must undergird the targeted efforts of the CDC and its Division of STD Prevention, a division who shouldn't bear a disproportionate burden to end this STI crisis. While Nate will focus on the federal efforts tied to this reinvigorated movement, if we are to achieve success, we must extend the reach of this activation and also hold to account non-federal partners, including local and state governments, public and private health plans, health delivery systems and networks, biotech, other national organizations, and pharma. So as we contemplate the creation of STD.gov to match HIV.gov, and the creation of an Ending the STD Epidemic initiative to match EHE, we must reflect on the marshaling of resources to fight COVID as inspiration to overcome chronic STI resource constraints. And as we remind ourselves that in an era of profound intersectionality between STI rates and other public health crises, we must remember that we can't end one epidemic if we don't end others. So I appeal to all of you to lean in and reach the activist potential that Dolores Huerta professed. Por favor, please help me welcome to the stage from the U.S. Department of Health and Human Services, Mr. Nate Fesick. Gracias. All right, man. Good luck.
Thank you, Mario. Good morning, everyone, and happy Pride Month. Yeah. For those who are sticking around, Pride this weekend here in DC, so if you're sticking around for the extra couple of days, it's Pride here in DC for those who want to stick around. But I want to say thank you to David, NCSD staff, the planning committee, volunteers, and all those working behind the scenes to make this event a reality. It's an honor to be with you all again. Nearly 1 year ago at STI Engage in New Orleans, we announced the first ever STI Federal Implementation Plan. This document highlights policies, research, and other actions that federal agencies will put into practice through 2025 to meet the goals of the STI National Strategic Plan. 16 agencies across 4 federal departments submitted actions to be included in the document, harnessing the spirit of a whole-of-a-government approach. Now, for those who are not familiar with the STI National Strategic Plan, it is our nation's roadmap to address STIs in the United States. The STI plan was released in late 2020 and includes 5 high-level goals and 14 indicators for measuring national progress. But one must ask the question, how have we progressed in the 4 years since this document was released? How are we doing collectively as a nation? We will publish a progress report in the very near future, and this report will include overall progress on the indicators. It will also include a high-level update of select federal actions, challenges the agencies have faced, and next steps agencies take to reach the goals of the STI plan. Today, I will share a preview of the indicator results. Here is an overview of the most recent results for each of the 14 indicators. You can see there are 7 core indicators at the top of the table and 7 disparities indicators at the bottom. On the side, you'll see the key to understand the icons and the status for the indicator. I won't read through the status for all of the indicators, but if you're looking at that chart, you can't ignore the lack of green check marks, which show an indicator has met or exceeded its annual target. And sadly, this should not be breaking news to anyone in the audience. Some STIs, including syphilis and congenital syphilis, which we've heard all morning, I know I'll talk a little bit more about here in a second, have been steadily increasing for the last number of years, reaching the highest rates we've seen since 1950. And these indicator results clearly demonstrate this in another form. However, there is cautionary cause for celebration. We are seeing some potential progress. Reported gonorrhea cases declined for the first time in at least a decade, while reported chlamydia cases were level. However, these cases are the highest they've been in a long time. The decreases in reported cases of gonorrhea are positive. However, CDC has shared they will need additional years of data to establish that this is really a true trend. Now, turning back to the indicator results, I want to highlight the red X's. These indicators, again, did not meet the annual target or actually moved away from their annual target. If you noticed, nearly all of these indicators were related to syphilis and congenital syphilis. During tomorrow's lunchtime plenary, you will hear from my boss, Admiral Levine, Assistant Secretary for Health at HHS, and other leaders in the field discuss not only the work of the federal task force, but also the work that's going on across the United States and in Indian country to address syphilis. And if I may for a moment, I want to just take a little detour and share some background on the early days of how that syphilis task force came to be. And for me, I think it's a good example of the power of national strategic planning and coordination, but it really, I think for me, highlights how we as the federal government, but also how our federal or non-federal partners and community have shaped and created this federal task force. So national strategic plans often have federal interagency working groups for implementation and monitoring of progress. During a meeting of the STI Federal Interagency Working Group about a year ago, colleagues from the Indian Health Service, or IHS, shared alarming rates of congenital syphilis in Indian country. The data caught our attention, and we took note. The following day, my office happened to have a briefing with Admiral Rachel Levine to highlight the release then of the STI Federal Implementation Plan. At the briefing, I shared the IHS data. As a pediatrician, Admiral Levine has a deep concern for babies' well-being, so the data had our attention. Not long after, it was like a day or two, Admiral Levine was calling up and requesting briefings from CDC, as well as IHS, to delve deeper into what was driving cases, but also asking the question, what are we doing about this? The growing concern coincided with pressure from the Presidential Advisory Committee on HIV and AIDS, groups like NCSD, advocates, community, all urging the government to do something about syphilis. And this really created the Federal Syphilis Task Force, and it is a true testament to the power of coordinated action. However, as we focus on syphilis, we must also keep our attention on improving sexual and reproductive health as it stands within the context of overall health and well-being for everyone across the United States. And I fully understand the strong headwinds we all face in doing this work. Among the many challenges, as Dr. Bachman just shared, dedicated STI fundings have remained relatively stable, declined if accounting for inflation, or have even been rescinded. Yet, you all continue to dedicate yourselves to responding, and you all deserve praise for your selfless devotion. And one of my favorite parts of this position is coming to conferences like this and traveling around the country to hear and learn from all of you in the innovative ways in which you're meeting the needs of your communities with really the little resources that you have. It's quite impressive. And really, as I come to a close, I want to encourage all of you to be on the lookout for the STI Progress Report, as well as the much anticipated herpes simplex virus to the STI National Plan. The goal is for both of these documents to be released this summer. When you see these documents, I hope you will get a glimpse at the many ways our federal agencies within and outside HHS are coming together to build new partnerships and leverage existing resources to address STIs. We also hope to expand on these efforts as we begin to plan for the future of the STI plan, which expires at the end of 2025. Tomorrow morning, we will also be hosting a session titled Federal Efforts to Address STIs in the United States, where I'll be joined by colleagues from the Bureau of Prisons, HRSA's Bureau of Primary Health Care, IHS, and SAMHSA. At that session, you'll be able to learn about the work that they are doing within their agencies to address STIs. Finally, I hope we all recognize that despite the continued increase in STIs, and despite the challenges, we are seeing progress. And much of that progress is a result of the passion and hard work you all do in your communities that you serve every day. And for that, thank you all, happy Pride, and enjoy the conference. Thanks, everybody.
Please welcome Becca Scranton and Jason Henry.
Welcome to STI Engage 2024. Greetings from the U.S. Virgin Islands and from our Commissioner of Health, Worcester and Encarnacion. I don't know about all of you, but we continue to see STIs in the territory.
Yeah, things are definitely starting to heat up in Arizona and across the nation. The last time that we were in DC for Engage was in 2019. And we are thrilled to be back in the nation's capital hosting the Engage conference once again.
Last year was the first time we got together since COVID-19. This year is the first we'll call the conference STI Engage. Behind the scenes, we've been working to update our terminology, hence we've dropped the term STD. We're happy to be with you again and to network and share resources.
In addition to the slight name change, one of the first decision points that we made last October was to choose the theme for this year's conference. We selected the theme of Shaping the Nation's Health because sexual health is deeply connected to our overall well-being, and too often, sexual health is neglected.
This week, we celebrate and reaffirm that sexual health is central to overall health, and that the nation's health requires equitable, sustainable, and syndemic response to sexually transmitted infections.
We will spend this week exploring past efforts, current trends, and future threats and opportunities to support the sexual health and wellness of the communities that we serve. It is no secret that we have faced substantial challenges, and there are more to come in the fight to reduce STI rates across the nation.
We are all deeply saddened by the loss of DIS workforce dollars. In light of this challenge, we have creatively found solutions to ensure continued service and delivery to our communities.
In Arizona, we have leveraged multiple funding streams to preserve service delivery over the past year, and we have expanded our screening recommendations, calling on providers to adopt routine screening in ERs, urgent cares, correctional facilities, and other critical touchpoints for care.
We are so proud to be surrounded by friends and colleagues from a wide range of professions: program managers, epidemiologists, clinicians, therapeutists, and more. Many have guided to share their expertise. We want to give a special shout out to our DIS. This conference was created with you in mind. You are our boots on the ground in the fight to connect people to care. Please stand and be recognized for your work. We have a lot of DIS here.
Yes, that's great. We are going to need each and every one of you in the years to come to respond to the rising rates of STIs.
Thank you to all who have traveled here today. We have many people joining us from the islands, from American Samoa to Hawaii, and of course the Virgin Islands. Now, if I'm not mistaken, this is the first year we've had representatives from American Samoa, Hawaii, and some of our other territories. So we'd like everyone from American Samoa to Hawaii to the territories, and of course the Virgin Islands, please stand so we can recognize you. All right.
We have so many people to thank for making this year's conference a success. We would like to invite our NCSC staff, conference volunteers, and planning committee members to stand to be recognized for the countless hours that went into organizing this event.
Yes.
And a very special thank you. Yeah. And a very, very special thank you to Elizabeth Finley, who's behind the scenes, and Stephanie White.
Yes. Next, we invite our sponsors to stand. Thank you for your generous donations. We could not do this conference without you. Thank you.
And finally, thank you to our fellow board members, and a special thank you to Jason for co-chairing the conference planning committee with me this year.
Well, you know, Becca, I'm still mad at you for abandoning me last year. But however, you did a great job and continue to do a great job of pulling us together and making sure we have a great STI Engage 2024. So, of course, we got to take our selfie.
What?
Hey!
All right, we have a ton of fantastic content for you this week. In addition to welcoming all of you, we also have the honor of welcoming our next plenary speaker, Dr. Ina Park. Dr. Park started her career in sexual health as a peer educator at the University of California, Berkeley. She received her medical degree from UCLA and completed a residency in family medicine.
Dr. Park moved to the University of Minnesota School of Public Health, where she earned her master's degree. Despite her love for Minnesota, she moved back to sunny California, where she completed her fellowship in sexually transmitted disease at the UC San Francisco School of Medicine.
Dr. Park is now an associate professor in the Department of Family and Community Medicine at UCSF and serves as the medical director of the California Prevention Training Center and a medical consultant for the Division of STD Prevention at the CDC. Since Arizona is in the California PTC service area, I have actually been a Dr. Park fangirl since the beginning of my STI career.
Have you?
Yes, I have.
So Dr. Park is passionate about sex. Everyone who's passionate about sex, let me make this noise. Woo! She's passionate about sex, positivity, and stigma reduction. In 2021, she published a book, Strange Bedfellows, Adventures in Science, History, and Surprising Secrets of STDs. Dr. Park currently lives in Berkeley with her husband and 2 sons, where she spends most of her time parenting and thinking about syphilis.
Ooh, don't we all? Before we welcome Dr. Park to the stage, she requested that we play a game of 2 truths and a lie. So, Jason is going to read the 3 possible truths first, and then I will reread each possible truth, asking you to applause for the one that you think is a lie.
All right. So 1, Dr. Park was a gospel singer in her former life. Do you all want to hear me sing?
Yes.
Karaoke.
Yeah.
2, Dr. Park has vandalized a public restroom with spray paint. Ooh. 3, Dr. Park has only been arrested once.
Oh.
Is she still your idol?
Absolutely.
Oh,
Yep.
my.
All right, now this time I will pause between reading each one, and when I read the one that you think is the lie, we want to hear your applause, okay? Make sense?
All right.
All right, number 1. Who thinks the lie is that Dr. Park was a gospel singer? She was never a gospel singer. Okay. About a medium applause there, all right. Number 2, who thinks that the lie is Dr. Park vandalized the public restroom? She would never do that. Oh, quiet on that one.
All right.
All right. And finally, 3, who thinks that Dr. Park has only been arrested once? Well, I think we're all dying to know the answer to that one.
Yes, we are. So let's put our hands together and welcome Dr. Park.
Thank you, everybody. So I have broken the law, and I did spray paint that bathroom, but I did not get arrested for it. And in my former life, I was a gospel singer, but I'm not that good, which is why I'm doing this whole syphilis thing now. But, you know, in gospel music, we sing a lot about good news. And so I was brought here today to actually give a little bit of good news, because we've had a lot of bad news, you know, with the Great Rescission, et cetera. And I tried to make myself Princess Leia for this slide, but I look better as Han Solo, and I'm just gonna be, you know, and I admit it, and I'm down for that. And whoever screams so loud for me, I think it's Wanda Jackson, by the way. But yeah, I know. Thank you, Wanda. So I'm gonna share the mostly good news with you today. We're gonna talk about syphilis screening and gonorrhea, new gonorrhea treatment, which is exciting, and vaccination. We're gonna talk about doxypep in the real world, because we know it works in clinical trials. And then our cousins in HPV are doing very well, even though syphilis is not, and I wanna tell you all about that. And then we're gonna do a little personal note and some syphilis story time with my colleague Jalen Smith from Georgia. So just to get us started, a couple months ago, actually 2 months ago, the American College of Obstetrics and Gynecologists issued new guidelines for syphilis screening in pregnancy. And so they are saying now that everyone who is pregnant, regardless of their, you know, risk or whatnot, should all get tested 3 times in pregnancy, which I think is great, yes. But y'all heard Dr. Bachman just say that 40% of the people who are having a baby with congenital syphilis didn't make it into prenatal care. So this is not going to help us for those folks who we can't get into prenatal care. And I think we need more wraparound social services for women who are experiencing homelessness or substance use or mental health issues to get them into prenatal care. But this is a great first step, and I'm excited about it. Remember, it's all good news almost for this talk. Is anyone from Birmingham, Alabama out there? Yes! Okay, so Birmingham, I want to just, shout them out because they really tried to get the word out there. At the end of 2007, Jefferson County was #1 for syphilis rates in the US. So they made these syphilis buses, as they came to be called, in May of 2008. But their mayor, Larry Langford, said, this is going to discourage tourism to Birmingham. So he pulled the ads off the buses, right? But I want you to know that we've come a long way. Is there anyone here from Toledo or Lucas County? Oh, no. Yes. Okay. Well, y'all are awesome because Toledo, Ohio, yes, they're using messaging that's simple, it's direct, and it's really based on the local epidemiology. About 1 in 5 of their syphilis cases are folks who are paying for sex. So they said, you know what? If you are paying for sex, come on in. And they increased clinic visits by almost 50% and reduced their rates of syphilis by 12.5% year over year. So yes, so everyone get a syphilis bus in your community. I think it's time. Okay, there's a one-word answer for this question. On the left, we have all the drugs for HIV. And then on the right, we have, there's actually an oral form of a cephalosporin, but there's the drugs for gonorrhea. There's one drug there, and there's a whole host of drugs there. There's a one-word answer for why this is. Does anybody know? Money. Well, yes, money and profit is what I was thinking about as well, is that, drugs for HIV we take when someone, contracts HIV for the rest of your life. But drugs for gonorrhea are a one and done. So there is no profit in antibiotics, and it does take money. Either way, it takes a lot of money to develop a new drug. So continuing on with my good news, there's a new treatment for gonorrhea called zoliflodacin, and we call it in our clinic Zoli. We were one of the clinic sites that did the study to get this drug, sort of pushing it out towards the market. This drug was actually developed by a partnership called the GARDP, and it's the Global Antibiotic Research and Development Partnership. So this is over 100 public and private organizations that are all in this huge coalition, and that includes pharmaceutical companies as well as universities, as well as health departments, because we know there's not a lot of profit in antibiotics. So they developed this molecule, and that's a gram stain of gonorrhea, and all those little red dots, tiny little red dots, are the gonorrhea inside of a white blood cell. And then my friend Oliver Bacon made this slide. It just, poof, disappears like smoke into thin air. So the Zoli study had about 930 people who had gonorrhea, and they did it over 4 years. And you could be symptomatic or asymptomatic, but you had to have the gonorrhea proven by either a culture, a NAT, a nucleic acid amplification test, or a gram stain, which is what you just saw earlier on that slide, or methylene blue, which is similar to a gram stain. And they did this all over the world in 16 sites, including sites here in the US. And it was Zoli, which is an oral medication, by the way, which is nice, so you don't have to get a shot. Yes. Versus ceftriaxone, 500 milligrams, and they also threw on a gram of azithro. So they knew already, because Stephanie Taylor actually down in New Orleans had looked at this, there's probably going to be a difference, and ceftriaxone was going to be a little bit better, but they wanted to make sure that Zoli was not, inferior by a lot. So they designed this as a non-inferiority study. And the good news is that it worked. So the primary outcome, which we're going to focus on, is that they were looking at cultures of the urethra or the cervix at the 6th day after they got treatment. They're going to publish a bunch of secondary outcomes also, but I want to focus on the primary outcome. The difference in the efficacy between Zoli and ceftriaxone was about 5%. And that's within the margin of non-inferiority. So this is looking really promising that we're going to have another oral antibiotic for gonorrhea. Yay. And the whole focus of the GARDP, though, is to make sure that treatments are distributed equitably. So the drug is not going to be available until 2026, and the focus is going to be on implementing in low and middle income countries first, and then also then to the US and other higher income countries. Okay, so anyone from Multnomah County, Oregon here? I really like your DoxyPep stuff, by the way. So Dr. Bachman already mentioned that there have been multiple trials demonstrating DoxyPep works in a clinical trial setting, 200 milligrams, any times up to 72 hours after sex, but the first 24 hours is better. And you'll see quoted from the US study about a 65% efficacy against gonorrhea, chlamydia, and syphilis. But I wanna separate that a little bit because it's about 50% for gonorrhea, so it's not as good. But the efficacy against chlamydia and syphilis is quite good, so it's about 80%. And so the city of San Francisco was the first city in the US to actually issue guidelines on DoxyPep, and they did sentinel surveillance in 3 clinics with a high percentage of men who have sex with men as clients. And they reported over 3,700 DoxyPep starts from November 2022 to November 2023. So I'll start with the bad news first. So before the pandemic, you'll see that rates of chlamydia, gonorrhea, and early syphilis were doing nothing but going up. Then COVID happened to all of us. And I'm going to focus in on the right side of the graph and what happened after the implementation of DoxyPep. So for chlamydia cases in MSM and transgender women, they saw about a 7% per month decrease in these populations and a 50% decrease overall in the time period where DoxyPep has been implemented. So that's really exciting. It's the first time we'd ever seen that from before the pandemic. For early syphilis, about a 3% decrease per month, and then again, a 51% decrease in that year-long time period. And so, remember I said it doesn't work as well for gonorrhea? We saw no changes in gonorrhea, and actually even an increase in gonorrhea in the implementation period after DoxyPep. And by the way, chlamydia in women, by the way, has actually gone up. And we do know right now that all the data is in men who have sex with men and transgender women. And so we don't expect there to be, an impact really on cisgender women. And at least in San Francisco, chlamydia is still going up for those populations, but syphilis and chlamydia are clearly going down. So this isn't a clinical trial. This is what we call an ecologic study. And we're just looking at what happened after a certain period of time. But I'm hoping that everyone out there who's implementing DoxyPep will also look at your data like this and let's see if we can drive down rates of these infections in populations that are disproportionately affected by them. Okay, I'm allowing myself one tiny bit of bad news, and that's here. But I'm gonna go over this quickly because I wanna keep the mood up. But what about meningitis B vaccine for gonorrhea? So this is Jean-Michel Molina from France, and in the original analysis that they published, they said it was about 33% effective meningitis B vaccine against gonorrhea. They are in the same genus and family. So in the final analysis, there was almost a similar sort of number of infections in both the groups that got the vaccine and didn't get the vaccine. And so the estimated vaccine efficacy then went down to 22%, and that wasn't statistically significant. So this headline, I think, says it all, which is full analysis of French STI study dashes hopes for gonorrhea vaccine. So this was taken at the Conference for Retroviruses and Opportunistic Infections 3 months ago, and they made him smile for that picture. But do y'all see, the rims around his eyes are kind of pink? This guy's been crying. He's been crying. But I will say that, there's still a study going on right now in the US, and they're enrolled, as well as Thailand and several other countries, called the MAGGIE study. So people are still looking at this, so I want you to know that it's not over for the meningitis B vaccine and gonorrhea. They're gonna enroll 2,200 participants, and they're gonna continue to enroll until they get 202 cases of gonorrhea, so it may be even bigger than this. And people will be getting either the meningitis vaccine or a placebo vaccine. And then they're going to be doing visits and a safety evaluation for a year. And so in San Francisco, the person who is the site investigator is Hyman Scott. And they interviewed him because he's out in the community getting MSM to enroll in the study. And they said, why should MSM enroll in the study? And he said, gonorrhea sucks. And I was like, that's real, that's true. And I think he pointed out it's more resistant to treatments. And so if we have another preventive tool like a vaccine, there's going to be less gonorrhea and less opportunity for resistance. So it's going to be a win-win. So I love Hyman. Thank you, Hyman Scott. And then finally, I'm going to close out with our cousin in HPV. The FDA approved self-collected HPV testing, and I know all of you out there and either know someone or you yourself have been behind for your cervical cancer screening because it's not fun to get a pelvic exam, just newsflash. And so now you can actually collect it yourself. And this woman this is the American Cancer Society announcement. This woman looks like she's about to run out and swab herself right away. Like She's so excited, and this is great because it works just as well as if a clinician collects it, and then it may reduce barriers for some women who do not want to, do a full pelvic exam. And the other good news for our cousins is that vaccine coverage for HPV vaccine is better in Hispanic and Black adolescents for one dose or for being up to date than white adolescents who are in the pink. And the only exception is American Indian and Alaska Natives, but multiracial, Black, Hispanic, and Asian girls are all doing better in terms of vaccination. And we've already seen in the 2 yellow arrows huge reductions in the types that are in the vaccine, including cancer-causing types. And an analysis down on the bottom that was just published in 2024 shows that the impact is the same, regardless of race and ethnicity. So I believe we're going to reduce cervical cancer in this country and reduce disparities for Hispanic and Black women. So I'm really excited about that. And our cousins just showing off now, okay? They're doing great. There's been a reduction already in 8 years in pre-cancer due to the HPV vaccine from 216,000 cases to 196. Okay. And then I don't know if you all have seen these DIS t-shirts. They're just flying off the shelves. But no, this is fake news, okay? But you can get either I love disco or I love disc golf. But y'all should have a t-shirt because I love DIS and we deserve a t-shirt. Yes. Yes, so thank you to my colleagues. And I just want to say, thank you to you. Sorry. Thank you to you. But I also want to take this opportunity. Yeah, thank you for laughing. I appreciate you that you like my jokes. And I want to bring out now a dear colleague, Jalen Smith from the Georgia Department of Public Health, so we can do syphilis story time. Yeah. Jalen Smith, hello. She's bringing me my old lady glasses because I can't read without them. Can I give you this? Thank you. Okay, so our first story opens with Nancy Spencer, who's a DIS in Denver, and she was trying to find out a client of hers named Rick who had gotten syphilis in a swingers club, and he couldn't remember the names of his partners. So she got entrance into the syphilis swingers club. I'm sorry, the swingers club, not a syphilis swingers club. She got entrance into the swingers club by calling up the manager, and they allowed her to come in. So here's where the story goes. She's with her colleagues, by the way, Anna, and her other colleague named Kinky Bob is his nickname because he likes weird situations. So on Saturday night, the three pulled up to a sprawling suburban ranch house in Denver and rang the doorbell. Rick had clearly paved the way for their arrival. A few towel-clad swingers greeted them as they walked by. And one of the swingers took them on a tour of the house so they could see how things were set up. As they passed the other members of the club, their host would say, "Here are the people from the health department." People nodded and smiled, promising to come by and say hi later. Spencer had brought supplies to draw blood for syphilis testing and a log sheet to record people's information. Along with Anna and Kinky Bob, they set up a testing area at the kitchen table, and one by one, the swingers began to drop by. Spencer and her colleagues took turns greeting them while the others drew blood and logged their information. They handed out the cards with the health department's phone number so the swingers could call the next week for their test results. Everyone was warm and welcoming and glad the health department was trying to help. Still, Spencer felt awkward and slightly out of place. She looked down at her street clothes and then all the people milling around just wearing towels. So she piped up, "I feel kind of silly with clothes on." She stood up, walked to the nearest bathroom, took off her clothes, wrapped herself in a towel, and came back to the kitchen. Anna and Kinky Bob followed her lead, and once in towels, they all sat down and resumed drawing blood. Now on equal footing with their hosts, they felt more relaxed. Demand was brisk that evening, and the three of them continued their work until well after midnight. As they were finishing, Rick, who was the index patient, came by. "You're done? Why don't you come and join us in the hot tub?" As they walked through the common areas, they glanced around to see if people were cruising for sex or having it out in the open, but saw nothing. The three of them walked over to the hot tub with Rick and a few members of the club, and they shrugged at each other as if to say, "What the heck, we already came this far." They dropped their towels, hopped into the hot tub, soaking with the swingers before heading home. Spencer came to the office full of stories on Monday morning, and her supervisor and colleagues were supportive of what she had done. And later, Spencer would reflect on the episode as emblematic of a certain time and place in their lives. Culture was different because that was the early 80s, before HIV/AIDS, before awareness of sexual harassment. People did crazier things. Today, I wouldn't do that. I wouldn't even get into a hot tub with my friends naked, much less coworkers and strangers. There was still a mystery to solve. Which of the swingers had infected Rick with syphilis? And later that week, Spencer received a call from the laboratory with the swingers' test results. They were all negative. "We never found out where it came from," she said. Even with the cooperation of Rick and his contacts, they had hit a dead end. And so dead ends are common in DIS work, but I want Jalen to come and share a story of how things went in the other direction.
So Charles Spann could not tell or could tell that this was going to be a very easy case. It wasn't the index patient's fault that he had been diagnosed with syphilis, but he was willing to help Fan track down his sex partners over the past 3 months. The patient knew most of his partners well, so they would be easy to find. But for one of them, the only identifying information the patient had was an online handle of SF JoJo. So SF JoJo. Fan looked at SF JoJo's profile picture, which showed a trim fit guy in workout clothes standing in front of a building. The photo was angled to show the signage for a local gym. The gym had several branches in the city, but Fan recognized the location based on the appearance of the street and the surrounding of the building. He made a simple deduction: a man in workout clothes in front of a gym, which probably means he was a frequent gym goer. It might not be correct, but it was definitely a start. So then Fan noticed something else in the background of the picture. In the distance, there was a man walking inside of the gym through the front door with a button-down shirt on or on a hanger slung over his shoulder. The man in the background was probably going to change into his shirt to go to work after exercising. Fan thought, if this was the case, SF JoJo had likely taken this picture in the morning. Perhaps mornings were his preferred workout times. Now they knew where and roughly what time of the day that they might be able to run into him. So Fan sent his team member Aaron to the gym to stake it out. Prior to Aaron's arrival, Fan had called the gym to let them know that the health department was looking for a member of the gym who had been exposed to a communicable disease. They had to know to ask who one of the offices so that Aaron could have a private meeting if needed. Fan had also asked if they could set up a table of informational brochures so that gym members could mingle with Aaron as they wandered in. They decided that the materials would be a topic unrelated to sex, so they went with helmet safety. So sorry. Aaron set up the table around 7 a.m., including placed stacks of materials about the city's helmet safety program. Gym members approached the table throughout the morning to take brochures and to chat with Aaron. She also informed the members about the other health services offered by the health department, including the city's clinics for TB, travel vaccines, and STIs. All the while, Aaron scanned and steady looked for the stream of easy gym goers or looking for SF JoJo. After 3 hours at the table, she spotted SF JoJo entering the lobby. She asked if she could speak with him and pulled him into the office set aside. After she had verified his identity with his picture and his handle, she told him he had been exposed to syphilis. He was stunned, and that this was the last thing he was expecting on his way to the gym that morning. He was grateful that the health department had found him. Skipping his workout, he walked 5 blocks away to the STI clinic to be tested and treated.
Woo. So these are just 2 of the thousands of stories that describe the work that DIS do. And so I just want to say, thank you to all of you. You are so wise, so tenacious. And we are just so grateful that you are you. We thank you for being here. We thank you for being you. And just give yourselves a round of applause.
Please welcome back to the stage NCSD Executive Director, David Harvey.
We have gone so over. You beautiful people are so patient with all of us. Thank you. A few weeks ago, I lost my 96-and-a-half-year-old dad. He had a wonderful, long life, and despite his health challenges in the last 3 years, you're just never ready, are you? It was a shock to the system. This is a universal human experience. Loss, challenges, the meaning of life, community, family. In short, all of you in this room. Teleprompter needs to catch up a little bit. There we go. Stop. Grief and joy. Anyway, all of us, through these life experiences, come together and work together for a common cause. It's these life experiences that drive us. All of you are making a difference, and from the bottom of our hearts, I could not thank you enough for being here today. A huge round of applause, please. My father said one of the wisest things to me that I have ever heard in the beginning of my career in Washington, D.C. in 1984. Yeah, I'm old. I have survived. He said, just remember, Davy, so he used to call me Davy, you're going to spend most of your time in your career figuring out how to get people to work together. And man, was he right. The rewards are rich when you figure out how to empower people to come together, like all of you in this room, to come together for a common purpose. This is the core element that you have heard running through all the presentations today and what defines successful social movements. This is the core element of NCSD's work. Becca and Jason shared a very important thank you to our board and staff earlier, but I wanted to add one additional thing. I don't know where out there in the audience Audrey McDuff King is, but today is her birthday. Audrey, happy birthday. Where are you, Audrey? Happy birthday and many more. There are a few things that I want you to know about the next couple of days. First, as you all know, June is Pride Month. We know there is pride in all the communities we serve. But June is traditionally the time that we take stock of celebrating the LGBTQ plus community. Your badge lanyards are the pride colors, and we have some special surprises in store for you tomorrow night. Drag bingo. I can't resist telling you about the last time I was actually on this stage. This place in this ballroom is historic for many reasons. The White House Correspondents' Dinner is held here. That's on TV every year. Presidential campaigns have had huge parties here. This hotel is the site of the attempted Reagan assassination, which did not succeed. This place is also the location of the infamous Miss Adams Morgan pageant, a yearly drag ball where performers compete for a crown and perform, sing, dance. It was not all that long ago that I was Miss Latta de Saint from the great state of Utah. Get it? Miss Latta de Saint? Yeah, okay. I think there's even a picture to show. God help me. There she is. For 28 years, this pageant has been going on, and all for a good cause, to raise money to support local STI providers. For 5 long years, I competed in the early 1990s. I told you I was old. I competed, and I never won a thing. So that showed you how good I was. I still have some lessons to learn. So a couple of additional quick notes before we close out this morning's session. So for lunch today, we're already behind schedule. For lunch today, head up 1 level to the Columbia Ballroom and make sure you visit our exhibitors. Our exhibitors and our sponsors, who are all represented there, is how we make this conference possible. So please go and talk to them, visit with them. They have important information to convey to you. Inside that same ballroom, this is the Columbia Room 7910, is NCSD's voting member meeting. Starting at about 1:15, well, it's going to be later now, so we pushed the time back just a little bit. But we'll have an update from Dr. Laura Bachman, who will get into a lot more specific stuff than her speech this morning. That portion of that meeting is open to anybody who would like to attend that meeting. I want to again thank Bavarian Nordic for being our lead sponsor this year. For anyone who is staying past the closing plenary on Wednesday, we are having a Mpox listening session. So check out the agenda for more of that. We need to hear from you about what's going on the front lines. I also want you to check out the OraSure and Direct Diagnostic booths in the exhibit hall for a chance to win free STI test kits. Thank you, OraSure and Direct Diagnostics, for partnering with us on that. They are joining our Check Yourself program, so make sure you check out all of that. In addition, 2 other key sessions I want you to pay attention to. There's an NIH listening session. NIH wants to hear from all of you. What are the research priorities in our field? And there's also going to be a Peached 2.0 listening session conducted by DSTDP. All of that is in your program app. So we are going to break now, but before we do, I want to do something that we started as a tradition at STI Engage. All of you stand if this is your first Engage conference. And maybe we ought to raise the lights just a little bit. This is your, wow, look at that. I can actually see you all now. Fantastic. Okay, sit. You're so obedient. Please stand now if you are an STI director. And we'll keep those lights up. Yes, STI directors. Okay, you can sit now. Stand next if you work in clinical services or research or are one of our federal partners. There we go. Now, everyone stand up. Here's your instructions. You are to introduce yourself in 15 seconds to someone that you don't know that's sitting right next to you. Say hello, introduce yourself and where you're from. All right, folks. Okay. That is great. The people that you just introduced yourselves are going to be the professional peers, networks, and friends that you need to sustain yourself in this field. This is not an easy field to work in, is it? The passion and dedication and low salaries you all have mean you really care about your communities. Network at this conference, make friends, use these relationships to sustain yourselves as we go forward. Together, of course, we are NCSD. Thank you all for being here. We're going to see you out throughout the rest of this conference. Thank you very much.